about the high flow oxygen device, and does it really make a difference compared to the standard oxygen devices that we're using currently or not? This device has a lot of different names, including high flow nasal cannula, transnasal insufflation, mini CPAP, nasal high flow, and high flow oxygen therapy. But actually, the most accurate term is the heated humidified high flow therapy, where it describes exactly how this device works. And it actually started to be used for neonates, especially patients who had bronchiolitis and respiratory distress of newborn and apnea prematurity and post-extubation period because of the mini CPAP effect it provides. And then later on, they found it useful also in adults. There's a lot of different companies out there in the market. We have Vapotherm, Aquanaze, and Optiflow from Fisher and Paykel. And we're going to go through these standard oxygen devices and their limitations and what actually does high flow offer in additional to these devices, and how does it work, how can it be used in different patient population, and its recommendation, the latest recommendation and literature in regarding to its application and management. So as we all know, main goals of oxygen therapy include either severe hypoxemia with a PO2 of less than 60 millimeters mercury, or patients who have increased work of breathing due to their stiff lungs, such as cystic fibrosis, bronchospasm, and to reduce their cardiac workload in case of congestive heart failure. So this table shows you the different standard oxygen delivery devices that we're using currently, and these are all considered low flow device. Because if you try to increase the flow beyond that, it will cause patient discomfort and nasal mucosal dryness. So we have the standard low flow nasal cannula, which provides a flow up to 6 liters per minute, and then a simple face mask, you can go up to 8 liters per minute. Then we have the partial rebreather and a rebreather, which you can go up to 10 liters per minute. And usually these are not kept on the patient for a very long time. These act as a bridge to either non-invasive or intubation. And then we have the Venturi device, which it has a unique property in which you can control the FiO2 according to the size of the orifice, and it's a color-coded system. Now, the problem with all of these devices, you have to keep in mind that patients who have respiratory distress, they start to increase their inspiratory flow up to 100 liters per minute in some conditions. And when they use this with these low flow devices, they tend to entrain more air, which dilutes the FiO2, which you set the patient on. So you have a huge difference between the set FiO2 and the delivered FiO2. The other problem with the CO2 rebreathing, because as we all know, the nasopharyngeal space acts as a dead space, so which accumulates CO2 with it. So with the low flow device, the CO2 cannot be washed, so they start to rebreathe the CO2, and this is very dangerous in case of CO2 retainers like COPDers. And the most important complication or problem with the low flow device is that they don't have a proper humidification. Even with the bubble humidifier, that doesn't provide optimal humidity. And our body actually has the optimal temperature and humidity to preserve the function of the organs, and one of these organs is the lung. And as we all know, that the lung is lined with ciliated ciliated epithelium, and this acts as a secondary defense mechanism where it expels any foreign object or mobilizes mucus and secretions. So when you give the patient dry gas, it will actually damage this epithelium and causes sloughing, congestion, and edema. And also the cold air will cause bronchoconstriction to protect the alveoli from getting this cold air in. So that will increase the airway resistance, and you get excess water loss and reduced mucociliary clearance. And this is what you get. Even as little as 5 minutes of delivering this gas, you will get a mucus plug, which can cause a lot of problems such as atelectasis and even lung collapse, which we don't want. Now, the non-invasive ventilation, as we all know, has a lot of uses and advantages. It can be used for COPDers and bronchial asthma exacerbation because it augments the alveolar ventilation and washes out the CO2. It also can be used in patients who you think might go into post-extubation respiratory failure because it recruits the alveoli, it keeps it open, and increases the FiO2 delivery. It can also be used for obstructive sleep apnea because it reduces the work of breath, and it can be used for congestive heart failure because it actually improves the function of the left ventricle. Now, the problem with this device is it has a lot of complications, such as air leak and eye irritation, retention of secretion, upper airway obstruction, gastric distension, aspiration. And it's a very noisy device, so patients will not tolerate it for a very long time. They get very uncomfortable, and it causes sleep fragmentation. And later on, it can even cause skin breakdown necrosis if it applied for a very long time, especially over the bridge of the nose. And even the literature have shown that it cannot be used for acute hypoxemic respiratory failure because it has a very high mortality rate and a failure rate up to 50%. So it's only been used for hypercapnic respiratory failure. Now this shows you the components of a high flow nasal cannula. It's a very simple device. Basically, it's composed of the nasal cannula, the nasal interface, connected to the tubing, which is electrically heated and humidified to preserve the temperature of the gas delivered to the patient. And then we have the humidifier and the air and oxygen blender. It has an excellent performance, can generate FiO2 up to 100% and a PEEP of around 7 centimeters of water at 60 liters per minute. And this is actually the highest flow that you can get. Patients tolerate it very well, and they actually prefer it to the face mask because they can eat, talk, and drink, and you can assess them much more easier. And it has a humidification of 100%. It has 4 basic mechanisms of action. The first is, as we said, it heats and humidifies the gas, so that will increase mucus clearance and increase the airway conductance. It has a very high flow, so that will decrease the work of breathing and respiratory resistance and increases the FiO2 delivered. It washes out the upper airway from CO2, so that will decrease the rebreathing and decrease the dead space, and it provides positive airway pressure, so that will keep the alveoli open and increase the gas exchange. Now, this interesting study shows you the effect of flushing the CO2 from the upper airway by the high flow nasal cannula. And what they did is they actually injected CO2 in the upper airway and applied the high flow at different flow rates. And as you can see here, this red color is fully saturated with the CO2 at 0 liters, and at 30 liters it starts to wash out slowly, and at 60 liters per minute you have 75% of the CO2 completely washed out. As we said, it has a PEEP effect, even with the mouth open. It has a pressure of 3 centimeters of water at 60 liters per minute, and there's a linear response to the pressure with the flow. So at 30 liters, you get 3 centimeters of positive end expiratory pressure. At 40 liters, it goes up to 4, and 50 liters, it reaches 5. Usually, you ask the patient to close the mouth to have a higher PEEP, but the problem is that you cannot exactly measure how much PEEP is delivered to the patient. And choosing the right patients is the most important thing. So any patients with any signs of respiratory failure, such as dyspnea, hypercapnia, fractional hypoxemia, increased cardiac workload and work of breath, such as patients who have bronchial asthma, COPD, congestive heart failure, and asthma and pneumonia. You have to keep in mind that the patient has to be spontaneously breathing, alert and oriented, and able to protect his or her airway, just as the same as non-invasive ventilation. And this diagram shows you how to properly choose the size of the nasal cannula. So we have the 3 different sizes, and it has to accommodate at least half the diameter of the nostril in order to have the optimal effect. These are one of the guidelines which shows you how to start the high flow nasal cannula and how to titrate your flow and FiO2. So any patient who have PO2 less than 80, saturation less than 90, CO2 of more than 45, tachycardic and tachypneic. The only difference between hypercapnic and hypoxemic is with hypercapnic we start with a flow of 40 and a FiO2 of 35, but in hypoxemic patients we start with 100% and a FiO2, and we decrease as the patient improves. So how do you know that patients are responding to high flow nasal cannula? The most important thing is that you have to monitor them closely in either the ICU or the HDU or the emergency department, especially in the first 30 minutes to 1 hour. So you look at the respiratory rate and the thoraco-abdominal synchrony, and you measure the PF ratio, which is the PO2 over the FiO2. In normal patients, it's usually anything above 500. So you look at the trend and see how patients are doing. And there's something called the ROX index, which they measure the saturation divided by FiO2, and then they divide it to the respiratory rate. So anything above 4.8 is a good indicator of patients' response. And of course, any signs of hemodynamic instability is indication for intubation and mechanical ventilation. So this is a real example of a patient who was 60-year-old COPD, a frequent flyer to the emergency department, and he came this time with another COPD exacerbation. He was tachycardic, tachypneic, and he had respiratory acidosis and he was hypoxemic. So after 1 hour of applying the high flow nasal cannula, as you can see, the heart rate came down from 124 to 113. The respiratory rate came down from 36 to 22. The pH came up from 728 to 741. And the CO2 decreased from 74 to 53, and that avoided the need for ICU admission and more invasive respiratory modalities. So this diagram shows you the escalation of therapy. So we usually start with standard device, and then we can consider high flow. If they didn't improve, then we go to non-invasive and mechanical ventilation if needed. When the patient starts to do well with high flow nasal cannula, what we do in weaning, we decrease the FiO2 first, and then when we reach less than 50%, we come down with the flow, and when you reach less than 20 liters per minute, you can replace them with the conventional oxygen device. So now we'll go quickly through the most popular trials which have been done looking at the high flow nasal cannula compared to the standard oxygen device. So we have the Florali, which is published in the New England Journal in 2015, and the BiPOP study, which looked specifically at patients post cardiothoracic surgery, and the OPERA trial looked at patients after abdominal surgery. So this is the Florali. It's a 23-center prospective randomized controlled trial. It randomized the patients to, they collected 313 patients, randomized them to either non-rebreather, high flow nasal cannula, and non-invasive. And as you can see here in the Kaplan-Meier curve, patients who are actually sicker with a PF ratio of less than 200, the high flow reduced the need for intubation, and it improved the survival significantly. They also looked at patients in the emergency department. They tolerated it much more better than the face mask, but we still need further investigation to determine whether it actually does reduce the need for ICU admission and intubation or not. It can also be used during bronchoscopy because, as we all know, in the bronchoalveolar lavage, patients tend to desaturate significantly, and when they applied it to these patients, they actually did much more better than the face mask. Also, patients who are not for intubation, such as metastatic cancer or for palliative therapy, what we used to do before that, we used to keep them on invasive ventilation, but as we all know, with all these complications, they cannot be kept on it for a very long time. So when they applied high flow, it actually decreased the rate of progression to non-invasive ventilation. It can also be used for patients who you think might develop post-extubation respiratory failure. And as we all know, reintubation is associated with poor outcomes such as increased incidence of ventilator associated pneumonia, increased mortality rate, and longer length of stay. So it actually reduced the risk of reintubation within 72 hours compared to the oxygen face mask. And in this trial, it was considered non-inferior to non-invasive ventilation. And one of the most interesting things, it can also be used as a method of pre-oxygenation during intubation. As we can see here, compared to face mask, they had a lower rate of desaturation, and it even increased their apnea time up to 14 minutes compared to 8 minutes with the face mask. And this is very important, especially with patients who were really oxygen dependent and cannot tolerate being off oxygen for a very long time. And this is also an interesting study. This is a randomized crossover study which looked at patients who were tracheostomized and were difficult to wean, and actually it does improve weaning from tracheostomy, but we still need stronger studies to come up with a strong recommendation about that. So in this meta-analysis, they looked at all of these studies and they came out with a conclusion that it actually high flow nasal cannula did reduce the need for more invasive respiratory modalities, but there was no significant mortality difference. So we still have a lot of unanswered questions, such as which patients exactly who had respiratory failure do well or can do better with high flow nasal cannula. We need strong recommendations about the predictors of high flow nasal cannula success, the optimal flow rate titration, and its cost-effective analysis and its use in chronic respiratory disease. But overall, it delivers heated and humidified oxygen at a very high flow rate, and patients are accepting it even more than the standard oxygen devices. It can be used in either acute or chronic respiratory failure, but the most important take-home message is that your decision on starting a patient on high-flow nasal cannula should be individualized in each particular situation. But it's a very innovative and powerful technique, and is currently changing the management of patients with respiratory failure. Thank you.